Thank you so much, sir. Okay, so starting with our first scientific session, inshallah, and hoping that we are heading towards a great conference for the next 2 days, approximately. So for the first scientific session, I have 2 speakers and 3 chairpersons whom I'll be calling just in a while. And before that, I'd like to request all of my audience to put their mobile phones on, either switch them off or put them on the silent mode so that the decorum can be maintained. So for the first scientific session, the first chairperson I'd like to introduce is the name which is well known, Professor Dr. Abdul Jabbar. He's a consultant endocrinologist and diabetologist at Medcare Hospital in Dubai. He's associate professor at Mohammed bin Rashid University, UAE, and he's also associated with Aga Khan Karachi for more than 20 years. So thank you so much for joining us. I'd like to request Professor Dr. Ali Java, one of the very, very humble and very great person, medical director of WellCare and consultant endocrinologist and past president of Pakistan Endocrine Society and ACE Pakistan chapter. So thank you so much for joining us. I'll also request Professor Saeed Meher, who is Professor of Endocrinology in NICVD Karachi, Director Academics Advice Academy, past President of PES and ACE Pakistan chapter. So thank you so much for joining us here. Before I request my first speaker to start his talk, I'll just want to make a point that each speaker will be given almost 25 minutes for the talk. I request kindly you stick to the time that has been allotted because of the schedule that has been, that we are supposed to maintain actually. So our first speaker is Dr. Atul Kalhan. He's a consultant diabetologist and endocrinologist in Royal Glamorgan Hospital, Wales. He's a visiting professor, University of South Wales, honorary consultant endocrinologist, University Hospital of Wales, Cardiff, and recipient of multiple prizes at European Neuroendocrine Tumor Society and British Endocrine Society. And something which actually caught my eye is that he's very into the sports and completed 1 marathon and dozen of half marathons in the last 10 years. Being a sports person myself, it was something that really, I really was excited about. So thank you so much for joining us.
It's been an exciting day for me. I landed up early in the morning after a 24-hour air travel. I've not slept a wink. I went to visit the old city and, found the house in which my great-grandparents lived before 1947. So highly emotional day for me. And I visited the old fort. I think I felt overwhelmed with emotions. So because the time is limited, I'm going to speak about hormonal method in madness. And the title is quite intriguing here. It's a very simple talk. There is nothing complex about it. In endocrinology, we are very attuned to, think we are very clever, which we are, and challenge our surgical colleagues, our other peers about what we know and what they don't know about. I'll start with a simple quiz. I think one purpose of this quiz is to get the audience involved. And, we are moving into the phase of day when our glucose levels must be dipping down. So there is nothing better than starting with a quiz. After the quiz, I'll go through a clinical scenario, and then there'll be some very simplistic take-home messages. As I said, there is nothing complex about the talk I'm going to give, but I think everything is linked together. So here are a couple of questions for the audience, just to wake them up, move them away from their mobile phones and the slumber which a late evening induces. If I ask you, which of the following is the most important hormone, and we are in an endocrine society meeting, this is a tester for you. Obviously, the answer is C. All right. No, cortisol. And, this is just a wake-up kind of question rather than anything deeper here. And I used to ask my medical student about which is the second most important hormone. And most of the men answered testosterone. I don't think that's true. So anyways. Second question is a bit more scientific as compared to the first one. How much cortisol is produced per day under physiological conditions? If you know the answer to this, I don't think I have to go any far in this presentation. So any takers for it? How many will say A? Please raise your hands. B? So I'm getting 1 or 2. C? D? E? So if I'm correct here, it seems majority of you are going for D, and there are certain ones who are going for C. And I can tell you this is the most important slide out of all I'm going to present, because if you know how much equivalent of cortisol is produced per day under physiological condition, you can deal with lots of things. So again, a show of hand for the C answer and D. Right. So it seems D is winning, but let me reinforce. Answer is C. Right? There is a paper from 1993 or 4 which comments upon 6 to 7 milligram per meter square, right? So, third question. What do you think is recommended replacement dose for prednisolone in secondary adrenal insufficiency? And I know Richard has mentioned about it. Our guidelines have changed, or I saw something very recent about it from a group in Imperial. So let's have a show of hands again. B, C, D. So it seems B is winning. I think it's even lower now. People are using 3 milligram, but 4 to 6 is when I had prepared the slide deck. So 4 to 6 milligram. Last question here. Which one of the following is correct equivalent dose for prednisolone 5? As I said, everything is linked together. So how many will go for B, C? Okay, D. Okay, brilliant. So I'll recap everything. Our physiological requirement for cortisol is smaller than what the audience perceives. For secondary adrenal insufficiency, we need 4 to 6 milligram, in fact, even lower. And equivalent dose of prednisolone with hydrocortisone is around 20 milligram. For dexamethasone, it's 0.75. The importance of it is linked with how much steroid is being used in primary care and how much iatrogenic adrenal excess we are exposing our patients to. So let's move to the second part of my talk now. It was back in October 2018, pre-COVID pandemic time. I had a 62-year-old lady who was hospitalized with 4-week history of altered personality. She was feeling extremely euphoric. Her blood pressure was quite high. And this was the first time during my ward round, somebody came in and stood next to me. So I went for the morning ward round. Patient jumped out of her bed and stood next to me and gave answers. So she was very hyper excitable. She had walked around 100,000 steps on a few days prior to admission. Let me reassure, she was not an athlete in any way. And she had gone to our little tuck shop in hospital entrance and spent around 350 pounds. And I can tell you, you can buy half of the shop based on the money she had spent. So she was going quite euphoric, uncontrollable, not on any medication. And medical assessment unit, they thought, oh, she needs a psychiatrist input. And let's start her on quetiapine. Right? It's an endocrine conference. There is no point for an endocrinologist to speak about a psychiatric patient. So, initial assessment, BMI very standard for the patients I look after, 28 kg per meter square. She was hypertensive, and there was an element of facial plethora. This is not an image, but I've used it as an example. So, the medical assessment unit team involved us because she was hypertensive. Next set, her white cells were mildly elevated, neutrophils were high, her potassium level were low, her urinary free cortisol levels were extremely high, so were midnight salivary cortisol. We carried out, as we normally do, the low-dose DEXA suppression test. And as you can see from the result, she had unsuppressed cortisol levels, quite by a wide margin. ACTH levels, the upper range for normal for us is under 60, and she was around 282. So very clear, easy diagnosis, isn't it? So it's a Cushing's disease, ACTH driven. Is it pit-based or ectopic? This is the only thing which comes to our mind. So why should I be presenting it in this meeting? So we started with thinking about ACTH secreting tumor, which is leading to this rapidly progressive Cushing syndrome. And we wanted to localize the tumor. So while we were waiting to localize the tumor because of the severity of hypercortisolism, we started her on a block and replacement therapy with metarapon and dexamethasone. Simple. So the next phase of our journey was to find out where the tumor is. We carried out a MRI PET, which was normal. Inferior petrosal sinus sampling, there was no gradient. We carried out an octreotide scan because of its relatively easier availability, which was normal. CT tap, which is a flavor for most of the physicians at the moment. Radiologists get very fed up of us doing this investigation, but in this scenario, we were looking for an ectopic source, but we didn't find any obvious source for this lesion. So we have our monthly neurosurgical endocrine MDT, and we discussed the details. We thought we are not moving in any kind of, there is no joy coming out of the investigations at the moment. So we'll arrange a gallium PET scan for her. Okay with it? So while we were arranging these investigations, she was putting on weight. She was not a classic Cushing's to begin with. She had started to put on weight, and this is her real life photograph. I've used it with her permission. And her mood swings were getting very difficult for her husband to manage. She had overt signs of hypercortisolism, which were not there while she had presented to us. And we noted that there was some kind of pigmentation, thinning of scalp hair, lots of other things which were going on, driven by the ACTH. She was initial blood glucose, which were normal. Now she moved into the type 2 diabetes zone for it. So we repeated a scan thinking we may find something, but all we knew was that she had bilateral adrenal enlargement and new vertebral fractures. So excess cortisol was contributing to this osteoporosis. Finally, we managed to get a gallium PET for her. It took us a longer duration than what we had anticipated. There was increased uptake in the pancreatic body and the tail. So eventually, we localized the source. We thought, is this 2.5 centimeter pancreatic lesion the source for the ACTH? There was some focal uptake in the left thyroid, but subsequent ultrasound didn't show anything. So in a sense, we thought it's a pancreatic NET, ACTH secreting neuroendocrine tumor. And then Feb 2020, the world changed. COVID pandemic hit, and all the plans for surgery and everything had to be delayed. So eventually, she underwent a distal pancreatectomy with regional lymph node removal at one of our neighboring hospital at Morriston. And the histology confirmed the diagnosis. It was a well-differentiated NAT. Ki67 was low, as expected of these tumors. And on a follow-up visit, she's still under my follow-up, and it's a joy to follow people who respond to therapy or management. Post-surgery, most of her phenotypic changes, which were there before, started to regress. She had nice hair growth, skin seems to be smoother. She didn't need any medication for diabetes and blood pressure. She was normotensive off medication. So, as I said, I was not going to take longer than few minutes, in fact, less than 20 minutes for the whole talk, because I wanted to stress on certain very important features here. Cushing's disease, Cushing's syndrome may present with mania and neuropsychiatric disturbance. I remember around COVID time, when huge number of patients were treated with dexamethasone, there was alteration in circadian rhythm and multiple other complications. The message I wanted to give, which is very important for primary care and some of the endocrine trainees around, please be aware of iatrogenic Cushing's. As I mentioned, my first few slides had a purpose. I just wanted to bring to your attention that our physiological requirement for cortisol is low, much lower than what we anticipate. And the doses of prednisolone we use in clinical practice is much higher. How often people with rheumatoid arthritis, flare-up of COPD, vasculitis receive more than 5 milligram of prednisolone, when in secondary adrenal insufficiency, our requirement for prednisolone is as low as 3 to 4 milligram. It sounds very simple, but there is a key message. I think as endocrinologists, one of the things which we witness around us is misuse of steroids, and there is a need for stewardship with steroid usage. And many of the time, over-the-counter prescription, the herbal prescription, these also contribute to iatrogenic Cushing's, and it's far more common than Cushing's disease we encounter in clinical practice. As endocrinologists, we are attuned to, look for exotic syndromes, and if somebody is hypertensive and hypokalemic, the two diagnoses which come to your mind are Cushing and Conn's. I believe Conn's is far more common than Cushing's disease, but in presence of type 2 diabetes and insulin resistance, it's the Cushing's which you need to consider. Last, not the least, ectopic ACTH secreting tumors might present with rapidly progressive CS. So as I said, it's a simplistic talk. There is nothing deep in it, but the reinforcement which I wanted to use in here was related to the dose of corticosteroids we use in clinical practice. We have found ectopic ACTH secreting metastatic parotid tumor, which we published years ago. I'm letting you read this take-home message. Once again, cortisol produced under physiological state is 9.5 to 9.9 milligram per day. And be mindful of impact of extra dose on mental health, metabolic complication, on the so-called low-dose steroids. With this, I'll keep it very short, and thank you.
Thank you. So thank you so very much. Very, very interesting case. I mean, we are just in the beginning, the first session, first case, absolutely interesting. Let's hear it from our experts, please. Can we have expert opinions? or comments?
Thank you very much, Dr. Kalhan, for an excellent presentation. It is eye-opening. Another learning point that I can see is that this is precisely the kind of case you can misdiagnose or underdiagnose if you're doing only telemedicine. You need both symptoms as well as physical examinations and investigation. So it's a very good case for learning point of view. Thank you.
Thank you, sir.
Thank you very much, Dr. Khan. I think so. That was very well presented and very well built up for the colleagues who are maybe not practicing pure endocrinology. But this is an eye-opener, what we have seen in the practice. Cushing is always a challenge for the endocrinologist to diagnose and treat. And as I absolutely agree with you, that majority of the cases are maybe due to the iatrogenic Cushing. Very well presented.
Thank you, sir.
Way in which you mentioned about the steroid dosaging and the daily production, and I was looking on the hand rise how many are able to answer those questions. It was interesting that some of these ectopic and Cushing's adenomas are so difficult to find, and at the end sometime you can't find it and you may end up adrenalectomy. But it was in this case very useful that you were able to locate it. What about the thyroid nodule which was identified? And as it came as neuroendocrine tumor, did you look for some other associated syndromes?
In a pancreatic background with normal serum calcium, I wasn't thinking of MEN1, and it would have been a MEN2 with the medullary one, but again they don't have the pancreatic NET as such. But in addition, we did a localized ultrasound and there was nothing. So if you go through the literature, this is becoming a more common reason for people to be referred to us with incidental detected increased uptake. The diffuse one is extremely common, relatively common. If it's a focal uptake, the recommendation is to go for a localized scan then.
And your case shows it is not easy to detect or identify on the routine imaging which we do, and need the nuclear imaging for that.
Yeah. Thank you.
Thank you so much. Do we have any question from the audience? We can take one question. Yes, please.
Assalamu alaikum. I am internal medicine physician. My question is that whenever there is a symptom or a sign, the basic principle of treatment is that first you have to find out an underlying organic cause. In this case, when the patient have symptoms like mania and overstepping, why the psychiatrist working in a first world country directly started on Cushapin rather to investigate underlying organic cause?
Medical assessment unit, and we were involved within 24 hours. So the initial thing, the patient was clerked by a journalist who don't have in-depth knowledge of endocrinology. So somebody coming with hypomania, they wanted her to be calmed down before anything can be done. So the good thing is we were involved within first 24 hours. So it's not that there was any delay, but I wanted to highlight the psychiatric part in here about how it can be misleading. And the last thing which I wanted to focus once more is how much pseudo Cushing's is more prevalent around with obesity, diabetes, and multiple other things. You see 1,000 people with probably pseudo Cushing's as compared to a true genuine Cushing syndrome.